Thank you so much for joining us tonight. To those of you in the audience here at the Women's Hospital at Skyridge in Lone Tree, Colorado, and to the hundreds of people, over 600 people across America who are joining us via web stream, welcome to you. We have 90 minutes of great information. I am Catherine Ormerod, and I am the Vice President of Programs and Partnerships at Living Beyond Breast Cancer. And on behalf of the organization, I want to welcome everybody. I also want to acknowledge our sponsors, Celgene and AbbVie. We could not hold programs like this without their sponsorship. I also want to thank the Rocky Mountain Cancer Centers for being a program partner here tonight. So, we are grateful at Living Beyond Breast Cancer to have great volunteers in the Denver area. We have 2 volunteers, Tony Jones and Jean Burns, who are here tonight, and one of our panelists that you'll meet shortly, Peggy, Valdez, Olivas. So over the past 24 years, Living Beyond Breast Cancer has been providing information and support, which is our mission, trusted information and a community of support. And we do that through a variety of programs. We do that by connecting people with trusted information. What does that mean? That means we have a medical advisory board that looks over all the material we put out. We also go to the other experts, the women and men who are impacted by breast cancer, and ask them to review our materials and tell us what they think. So, from the moment you're diagnosed through your breast cancer treatment, we have information for you. And we also provide it in formats that you like. For the technically savvy social media folks, we have Twitter chats. We have blogs which have first-person stories on them. And we have a very active Twitter, yes, and as well as Facebook and Instagram communities. We have webinars every month. We have a Young Women's Initiative. So young women are impacted by breast cancer differently. So we have a unique program for them. We recently started to provide a text service for them, and you can find out more about that on lbbc.org. We also have a large-scale conferences that we bring twice a year. And I'm very pleased to say we'll be back in Denver in September 18th through 20th, for our conference. We'll bring a national audience here, and it's called Individual Treatments, Shared Experiences. So we will have different tracks for triple negative, for metastatic, and also ER positive, HER2 positive. And we'll also have information for caregivers and young women. So please join us in September. So we are today here focusing on triple negative. And as the title, Breast Cancer 360 says, we will look at it from every angle. You'll be able to text in questions after we speak to our wonderful panel of experts. We will flash up the phone number, and both the in-person audience as well as the web audiences will be able to text your questions. If you're in the in-person audience and you're saying, hey, I don't like this texting thing, you have gotten papers and pencils in your bags, and you can write your questions down, and volunteers will take your questions and we'll put those into the mix. But this is part of LBBC's mission, getting cutting-edge practitioners and connecting you to them and to the latest information. Also, for those of you who are Twitter people, you can join a Twitter conversation. The hashtag is BreastCancer360. For those of you in the audience, please put your phones on vibrate and participate on that Twitter feed also. This program will be available by live stream immediately tonight. You go to livestream.com and put in Living Beyond Breast Cancer, and you'll see a menu and you'll be able to access it. We will also then put it on our YouTube channel next week, and you can get it through there. Many people find it helpful to go back and I thought I heard something, I need to review it, so they go back and look. You can feel free to do that. Others have used support groups where they'll get together and watch it together and then use it as a time to take further questions. So with all that said, let's get going. I'd like to introduce you to our panel of experts. To my right, we have Dr. Scott Sedlacek. He's a board-certified medical oncologist and an internal medicine physician with Rocky Mountain Cancer Centers, both in Denver and in Lone Tree. He specializes in the treatment of breast cancer and women at high risk for the disease. Helen Coons, PhD, is a board-certified clinical health psychologist with over 25 years of experience with women and men with cancer, oncology health care providers, and cancer advocates. She is also a member of LBBC's Medical Board. Linda Cooper is a licensed clinical social worker with Rocky Mountain Cancer Centers, and she joined them in 2008. She came from Chicago, in fact. She's worked as a social worker in oncology, psychiatric services, and she is especially committed to working with older adults on their cancer journey and advocating for all cancer patients as they cope with quality of life issues. And then, lastly, but not least, we have Peggy Valdez Olivas. Peggy is LBBC's breast cancer helpline volunteer who lives here in Denver, and she was diagnosed with triple-negative breast cancer in 2008. So welcome, panel. To set the stage for today's discussion, I want to introduce some key findings that LBBC discovered when we did a survey of women with triple-negative breast cancer. We had long provided tailored information for women with triple-negative breast cancer, and we did so in partnership with the Triple-Negative Breast Cancer Foundation. We have a brochure, we provide webinars, and we partner with them on the conference that I was talking about on the triple-negative track. But we kept hearing the same kinds of things from the women in those tracks, that they were really frustrated that some of the cutting-edge treatments they were hearing about were not available to them. There was a lack of information, and they were scared, and they felt their needs were not being served. So as our practice at LBBC, we did a survey, and we had over 2,600 people respond to the survey, and a quarter of them were women with triple-negative breast cancer. We took the findings, and what we discovered will both resonate with you and not surprise you. We discovered that fear of recurrence is especially strong, almost twice as strong for women with triple-negative breast cancer. And women with triple-negative breast cancer experience greater anxiety and worry all along the way of their breast cancer diagnosis. Even for those women who do end treatment, at the end of treatment, often you find that anxiety and worry lessen. But for women with triple-negative, they are still significantly higher than women of all other subtypes. And another interesting piece of information is that when they were diagnosed, 40% of the women said they did not understand that there were subtypes to breast cancer. So that was kind of a surprise. So with this as a backdrop for our discussion, I'd like to pose some questions to our panel. And for the first question, I'm going to start with Dr. Sedlacek, and I'm going to ask him just to define triple-negative for anyone who doesn't know. And then Dr. Sedlacek, if you could share with the audience when you first heard about triple-negative breast cancer and why you think this diagnosis impacts women differently than hormone-positive women.
Thank you. Triple-negative breast cancer is describing 3 different prognostic factors that we've known about breast cancer for decades now. The estrogen receptor protein is a protein on breast cancer cells, present in almost 75% of breast cancers, signifies a cancer that may benefit from an anti-estrogen hormone medication. The second is the progesterone receptor, and very similar to the estrogen receptor, signifying a hormone-sensitive cancer. And the third leg of that triple negative is the HER2 oncogene, which we now know is present in maybe 15% of breast cancers. And so 85% are negative, but the reason these have been kind of put together is if you have one of those three targets, we have targeted therapies. We have hormonal therapies for patients who express the estrogen or progesterone receptor. And we have this antibody for patients who are HER2 positive, trastuzumab, and its trade name is Herceptin. And therefore, we have the ability to specifically target that cancer cell with a specific treatment for their cancer. If you don't have one of those targets, we're left with traditional chemotherapies, which are basically poisons to kill rapidly growing cells, which we know cancer cells are, and specifically triple-negative breast cancers. So that's what the definition is. We're defining a group of patients that we don't have a targeted therapy for. And this term, we've known about estrogen receptors going back to the 1970s, the progesterone receptor late in the late 1970s. HER2 oncogene is the newer leg of this triad. And it was Dennis Slayman, who is a PhD at UCLA, who was working with the HER2 oncogene, finding that it had something to do with growth of breast cancer cells, that started developing this assay and developed in conjunction with Genentech an antibody to treat those patients with that target. And so we started doing, actually here in Denver, we were one of the 10 sites in the country that had access to Herceptin in the very early days of seeing how if this drug was going to work in 1995-96. So we were doing HER2 oncogene analyses on newly diagnosed breast cancer patients in the mid-90s. And we just called it estrogen receptor negative, progesterone receptor negative, HER2 oncogene negative. It really wasn't until 2002 someone put the term triple negative breast cancer together to define this group of patients. And now has really caught on in our medical press. I mean, I'm pulling out articles every week from some medical journal about triple negative this, triple negative that. And now it's catching on into the lay press as to a defined group of patients with a specific subset of breast cancer.
And how do you find your patients? How do they differ from women who are estrogen positive, who are triple positive, if you will?
As you mentioned, your survey, they have more anxiety because people now know what this term is. And there are websites, and you can go to the internet and read about it. They come in more frightened. They know they have a more aggressive cancer and definitely more apprehension from the very get-go.
Okay. Dr. Coons, you've worked a lot with women with triple negative. How do you see them coping with the diagnosis, and what are some observations you've made in your practice?
Well, it's a great question. There's no question that when I see women across the lifespan with triple-negative breast cancer, they come in with a heightened anxiety, has been mentioned, especially in increased fears of recurrence above and beyond what we see in women who are positive, estrogen or progesterone positive, or express the HER2 gene. In addition, certainly seeing younger women who already, we know, have even higher rates of anxiety in general, but who are triple negative, have another level of anxiety. And I have a long history of treating African American women who have an increased rate of risk for being triple negative. In addition, historically, I've seen a lot of women who carry the BRCA1 gene and go on to develop breast cancer, and in fact, again have an increased risk. So I would see this further elevation of anxiety, not feeling understood with the mainstream of women coping with early and advanced breast cancer, having a lot more questions about how to cope with uncertainty, and I think feeling less supported, especially early on, as you mentioned, 10 years ago, and not feeling like there was much information, wondering about clinical trials, not feeling like family and community understood, well, there are increased levels of anxiety. And as you pointed out in the LBBC, very important data, that their anxiety didn't necessarily go down after acute chemotherapy because of the elevation of risk for recurrence. So I'll look and say more.
Linda, can you expand on that? Because you too see many patients.
I think the one thing we often tend to forget is the fact that when you are looking at younger breast cancer patients, you are looking at women and men who still have children in the home, who are raising families, who going through a treatment with chemotherapy and surgery and radiation may present a huge financial crunch for them, simply because nowadays most people, in order to raise a family, truly need 2 incomes, and most certainly somebody has to have insurance. So I think that just adds to everything that's been said before.
Financial anxiety,
Yeah.
as well as the emotional anxiety. Peggy, on our panel, like many in the audience, you were diagnosed with triple-negative breast cancer in 2008. What did you know when you were diagnosed, and what have you come to learn and understand?
After listening to the panel, I feel like a textbook case. I didn't know anything about triple-negative breast cancer when I first heard about it from my oncologist. I didn't even know that there were different types of breast cancer. And I was talking to a coworker who was also a breast cancer survivor, and she said, "What type do you have?" And I told her triple negative, thinking that was probably okay because I wasn't going to have to take hormones. So I thought that was probably okay. And the look on her face said it all to me. She was obviously distressed for me. I didn't know what that meant, so I did what probably most of us would do. I went back to my desk and Googled, what is triple negative breast cancer? And obviously, yeah, that was probably not the best thing for me to do that day. I read my journal last night that I was keeping at that time, and I was completely discouraged at that time. But I had a really good chat with my oncologist about what that means, and he said, I assure you, I'm treating you for triple negative breast cancer the best that we can. And so I just knew I had to move forward from there.
Good. Dr. Sedlacek, as Peggy said, she went on the internet and all sorts of horrifying information came up to her. What myths do you hear from your patients, and what kind of impact do they have on them, and what advice do you give them?
I try to educate them on the fact that, yes, indeed, you have an aggressive cancer, and they've been on the internet and they've seen all these bad things, and their friends, their faces drop. Oh my God, you have got triple-negative breast cancer, which is the bad news. The good news is, if there is some good news in all this, is that we have developed some very effective chemotherapies. Granted, it's not targeted therapies, it's non-specific therapies for rapidly growing cells. But the good news is they have the most chemosensitive of all the cancers. The slow-growing cancers that are hormone receptor positive, they don't get nearly as much benefit from chemotherapy as the triple-negative breast cancer patients. So I try to set the stage for there is so much we can do for you. And they're doing studies on how to schedule the chemotherapy. Instead of every 3 weeks, we've now learned that giving it in what's called dose dense every 2 weeks makes a big difference on reducing the risk of recurrence. And with the advent of the taxanes, Taxol and Taxotere, has significantly improved survivals. I also, there's a recent study, I actually brought it, I show it to all my patients, that back in the late 80s to early 90s, this was what your risk of recurrence was by year, and for triple negatives, it peaked at 1 year and was still pretty high through years 5 and then tapered off. But now with the new treatments, that peak is pretty much gone, and by 6, 7, 8 years, there's a very good chance you're not going to recur and you're probably cured.
Dr. Coons, what myths do you hear, and how do you go about dispelling them, particularly around the levels of anxiety and worry that we heard about in the survey? And I see people in our audience nodding as we talk about this.
Well, I think it's a really important question because it comes back to patients' assumptions. They get those responses from friends, or they read something on the internet, or everybody lumps breast cancer, early, advanced, all kinds of types in one category. So the first is to get a sense of whether patients are actually and their families have accurate information. Because of the very good points that you just enumerated, we have good treatment and better treatment than certainly 15, 20 years ago. And so that to kind of watch the overriding assumption that there's no option and it's hopeless, since that's not what the data suggests. I think the other thing is to help patients and their families understand that they're not alone, that there's a significant portion of women across the lifespan coping with and living well with triple-negative breast cancer, in remission or not, and there is a support community to decrease the isolation. I think one of the other ways in which we really work with really all women and their families coping with cancer, but especially women with triple-negative breast cancer, whether early disease or advanced, is to find ways to feel more in control and empowered around your health decisions and treatment decisions. It may be suggesting to getting a second opinion. It may be looking into a clinical trial. It may be really being more empowered around taking care of one's emotional health to reduce that anxiety.
Linda Cooper, just to add a different perspective, when you and I were talking, getting to know each other before this discussion, you said something very interesting to me about how some of your patients will turn to different family members or friends at different times. Could you expand on that a little bit?
I think that as you look at the variety of expertise on this panel, and you think about the variety of expertise within your own circle of friends and your own family, oftentimes we think there's only one or two people who are really our support. And over the course of this illness, I highly recommend you rely on different people for different things. There is a time to ask Dr. Sedlacek a question, and don't ask me. Go to the expert. There are times that you really should reach out to Peggy, because this is someone who, better than all the rest of us, has a real sense of what you may be going through and has 7 years out to share with you. There are times you really need to sit down with a counselor and spend some time looking at how you're feeling. There are times you may want to use a social worker. Don't become isolated in looking for help, because you will limit yourself, and quite frankly, you will exhaust yourself trying to keep all these ducks in a row when there really are individuals out there who are willing and have the expertise to help you.
Peggy, can you provide a little insight into this? Some myths that you heard, your friend's face fell, your coworker, but were there myths that you found especially troublesome that you would like to break through?
I think for me there were two myths that came to light, and ironically they are polar opposites. The first myth was, you can't survive this. You're not going to survive triple negative, which is a complete and total myth. The other is, it's breast cancer. It's pink, it's pretty, it's not real cancer. And so, trying to reconcile those can be difficult, and they're both obviously very harmful to a patient. You don't want to give anybody who's got cancer the indication that they can't survive it. You can't survive it. I'm 7 years out. I know plenty of people who are survived it longer than I have. But on the other hand, it's serious. It needs to be taken seriously. Let's not just slap a pink bow on it and pretend like it's not cancer.
That's an excellent point. So, Dr. Sedlicek, when you first meet someone who has been diagnosed, or you are diagnosing with triple negative, what are the important things you want her or him? I don't know if you've seen any men, but men, of course, do get breast cancer as well. But what are the most important things for people to know?
It's a matter of getting their ducks in a row, getting their support system together, and knowing that they're not alone through all this. But a lot of it is just education. Giving them the information to know that we do have very effective therapies. We'll sit down and spend hours or more talking with the patients about this is the program we think is best tailored for your cancer, your personal health right now. We have chemo teaching classes where they'll sit down with our nurses and talk about this is how we're going to manage this and that we can get you through this. I mean, half of my job is really cheerleading and playing psychologist to get them. Sure, I'll tell them what chemo drugs to use, but it's tough. And the younger a woman is, the more support she's going to need to get through this because she's got kids at home. She's juggling a job and family and maybe a parent at home also. So we try to empower them with information. Give them the information that they need to know that they can get through this.
Peggy, when you are on the breast cancer helpline for LBBC, what are the things you tell what are the things you want to tell women who are calling with triple negative?
Well, probably the most common question I get on the helpline from women with triple negative breast cancer is, how do you manage your fear of recurrence? When does the anxiety go away? And what I tell them honestly is, still working on it. And I'm 7 years out now, so I don't think about it every day. I'm not even sure I think about it every month. It gets better and better as time goes on. But I can't, I got to be honest, every time I step up to that mammogram machine, my head starts spinning, and come October, obviously, information is right there in front of you. So I tell them that, anxiety is normal. That's a normal feeling, and to reach out when they're feeling anxious. And you don't have to read every article that comes out about triple negative breast cancer. That's not necessarily going to be helpful. So just try to temper it. Anyway, that's probably the most common question that I get.
Linda Cooper,
Yes.
when with this fear of recurrence that keeps coming up, some people, as Peggy described, it starts like tapes start playing in your brain. We've heard that a lot. How can people try to manage that anxiety? What are some tips you give?
First of all, I really think we have to acknowledge it, and we all, oftentimes, we simply try to tap it down. We ignore it. I'm going to get through this. I've got things I need to do. I have a job. I have kids to raise. Is to acknowledge it, and then to take the time, which often is so hard to do, to really determine what works best for you and to try different things. So it may be something as simple as learning breathing exercises. So when that anxiety washes over me, I can take 4 deep breaths and sort of calm down for a minute. It may be working with a therapist like Dr. Coons to really address what it is. It may be talking to someone who's been there. For me, there is no pat answer. I think the key lies with each man and woman who's facing it, and maybe my job is just to tease it out a bit, to encourage you to try new things, but to recognize that long before you got this, you had coping mechanisms, you had resilience, you got through life. So how can we get through this?
Dr. Coons, you want to add something to that?
I think my colleagues are right on point, really inviting patients to acknowledge the anxiety, to get support, understand what some of the women in particular are very good at what we call rumination, going over and over and over in our head about issues that worry us, and that actually creates an increased risk for anxiety and depression and less problem solving. So we want patients to talk about the anxiety, get support, not be alone with those feelings, figure out how to take the best care of yourself now, plan for the future, and then live today, and figure out what the philosophy or kind of your approach to living well today is. To just stay in that overwhelming anxiety and not really being present then robs an individual of the richness that they have here and now, whether that's with early disease or advanced disease. Some individuals really respond also in terms of tapping down that anxiety. You mentioned breathing. There are individuals who do really well with increasing their aerobic exercise if they've gotten their physicians or their oncology team to approve that. There's other individuals who do really well with prayer. There are a subset of individuals for whom distraction and getting out of their head works well. Sometimes people just need a hug. Other people really benefit from medication at the right time. And we could talk about a lot more coping techniques. I think the other thing you said is to really find ways to use the resilience that women have. Women cope incredibly well with breast cancer. That doesn't just disappear in the face of triple-negative breast cancer. And to kind of tap into how are you already coping with your job and caring for your young children or your elderly parents and doing 6 things in the community. So, but coping well doesn't mean it's not hard. And so those gets confusing. And there are days when women feel really empowered and other times when it's just overwhelming. And to make sure women have support for that.
I would like to make one point that we've been all trying to make sure we don't forget the men in the crowd. As it turns out, we're not talking about men. Men are hormone receptor positive. 100% of all the men I've ever seen, and I've seen 27 men, they've all been estrogen receptor positive. So they actually do not fall in this category. So we're actually just talking about women.
Great
Point of clarification.
Thank you, Dr. Sedlacek. Can you also, Dr. Sedlacek, talk about side effects and treatments from chemotherapy and how you help your patients get through some of the negative impact, which certainly feeds into many of the fears, etc.
Yeah, and a lot of it is being honest with patients. I don't want my patients to be surprised about side effects. We'll be very upfront about it. We are very good at preventing nausea and vomiting. It might take 5 different drugs, but most people today do not vomit. If you vomit the first time, we didn't do a good enough job. You might need different drugs. So, and we've got a whole passel full of new drugs we can try. So some people just absolutely fear to vomit. We've got great drugs. We can prevent that almost all the time. We'll get better every time we treat you. The one part that's the hardest is the hair loss. That is, there's no way of getting around. We have not developed a program in the at least in the adjuvant setting, in the preventative chemotherapy program where we can prevent the hair loss. But I tell patients it's going to come back. It may come back curly. You may get a chemo curl out of it. 75% of people get a chemo curl. It's the longest perm you'll ever have. It'll be 1.5 years. We don't charge any extra for it. It might come back darker. So a lot of it is just being upfront, talking to our nurses, getting through, okay, if you get mouth sores, this is the program we do to treat your mouth sores. 10% of patients get it. Be honest about it. Muscle aches you might get from this drug, bone aches from that drug. We have treatment for those. And I tell patients the first dose is the hardest. You're scared to death. You've never done this before. You've heard all these myths and things about chemotherapy, my gosh. If you can get through the first dose of chemotherapy, you can do anything. You are tough. And indeed, everyone will get through. And we'll get better every time we treat you because we'll learn what works best for you. So information, being honest about it, and knowing that we've got great treatments.
Great. Peggy wants to add something. Go ahead.
It's all coming back to me now.
Is this good or bad?
I think the thing that I was most surprised by was the fatigue. I heard about the nausea. Obviously, I geared up for the hair loss, which actually I found kind of freeing myself. I didn't mind that as much. It was the fatigue. I was not prepared for that. The debilitating, lay in bed for a couple of days fatigue. I don't know if there's, I think that's the one thing probably that I would have wished I would have been more prepared for.
Is there anything people can do to prepare?
Yeah, I'm really glad you brought that up. So it's no surprise to the men in the room that women don't ever sit down. And at any given time, women are thinking about, I can see what's going to happen here. You're all starting to nod your head. Dinner, work, the kid or grandchild doesn't have shoes for the fall. There's homework to do. There's the community event. Mother-in-law's birthday, God forbid their husband or his partner would get the gift. Dinner for the family, I'm seeing a lot of, you get that. So women don't stop, and I think it's very common to override the cues of cancer fatigue and just keep pushing. And then what happens is, so we get activity, and then with increasing fatigue across chemo, increased crashing and more difficulty. And so one of the important things is to actually start to pace oneself and listen and override our ever-ending long list of to-dos. Start to ask for more support. Learn to stop, even if you're working full-time through all this. And so that's a big piece. And if you're not, the second piece I want to add to that is women in general have more difficulty with getting to sleep and staying asleep as a base rate. And then you add many of the medications that we give during chemotherapy and the stress and other responsibilities, and so sleep can be very problematic. And we really want to know when you're having trouble sleeping, because then your energy is further diminished. There's a lot of biological reasons why we want you to sleep well. But also, if you're going to make good treatment decisions, adhere to the many kinds of interventions and exercises and protocol, you have to sleep well. And quite frankly, if you're not sleeping well, it diminishes your quality of well-being, period. So you want to tell your oncologist or any part of the cancer team if you're not sleeping well for more than a night. One night, okay. More than a couple nights, we want to hear about it.
Linda.
And we want to hear you're fatigued. Do not decide you're going to suck it up and not share. You know, that I can get through this. Over 74% of all women going through cancer treatment have fatigue. So I think you've gotten wonderful suggestions, and to sum it up, be gentle with yourselves.
That's wonderful advice. So we at Living Beyond Breast Cancer and in other cancer organizations, cancer does recur, triple negative, and people become metastatic, or sometimes they present with metastatic triple negative breast cancer. So what do you tell your patients? How do you deal with your patients who have metastatic breast cancer? How do you help them to live through the best quality of life that they can with this disease?
Well, as an oncologist, we wear a couple different hats. We've got the adjuvant, I'm going to cure you hat. We're going to push hard because giving you aggressive chemotherapy, dose dance maybe every 2 weeks, we have data to say this is really going to make an impact on your being cured and living for the rest of your life a normal life. When we have a patient who has recurred, has metastatic disease, we put on a different hat. We put on our palliative hat. That hat is trying to give that patient the best quality of life and quantity, which is a real art of how hard can I push this patient? How hard do I need to push, yet still maintain the best quality of life? And so we've got, fortunately, 20 different chemotherapy programs that we can juggle around to fit a particular patient's situation. Some have different toxicities that we might have to stop a medication even though it's working because she's getting neuropathy and she's dropping her dishes and glasses. Okay, we got to stop that and try a non-neurotoxic program. So it's really giving that quality and quantity together, knowing full well that I don't necessarily have a cure for this disease. And because of that, I'm always looking for better options. I'm looking for better treatments, looking for different research opportunities for patients to try to find that magic bullet, to find a new targeted therapy. It's not ER, PR, HER2 new. You don't have those three. But we're looking at new targets and wanting that woman to step up and be willing to try something new, because that's how we advance science and medicine and find these amazing new drugs like Herceptin. We had 15 women in 1992 who were willing to try this drug, this antibody. It's never been tried before. And one of those ladies is still alive today. And she got 3 months of therapy because that's all the drug they had. She was willing to take this chance. And people are willing to try new treatments.
Linda Cooper, how do you cope? How do you help a person through a triple negative metastatic diagnosis?
It seems to me that sometimes my job is simply to ask, what's important to you? And then work in being certain that everybody else on the team knows that. And to not just ask it once and say, well, I've done that for today and we're finished. But throughout the course of the whole thing is to say, have things changed? We change as individuals, our families and those people we count on change and grow, is to constantly be the one who says, what's really important to you? And I've had people say things to me as simple as, my kids can't remember me as being active. So we begin to share that information to see if there's a way, yeah, we're not going to get you back to your mountain biking, but is there a way so that you're not so fatigued for this? So that's probably the most important thing. And I would say you really don't need me to ask that question. When faced with this diagnosis, begin to take a look at what's most important to you and communicate that to your healthcare team and communicate that to your whole support team. This is what I want from this time, and this is how I'd like to live it.
Dr. Coons, anything to add?
And I think that's really well said, and kind of getting back to what somebody's passionate about and what's important, and also coping with the uncertainty. Finding ways to acknowledge those fears, again, finding ways to get more information, get a second opinion, find out what clinical trials are, be active, be proactive in managing the new diagnosis of advanced disease in the context of triple negative breast cancer. Going ahead and putting plans in place if you have a dependent child or a dependent adult that you're responsible for. Oftentimes women will come to me and say, I don't know whether it'll work or not. And it becomes very clear, trusting that you know what's best for yourself. Making those plans for the future, and then again, finding a lot of clear ways to be present with yourself and those who are important to you, and focusing on what you're passionate about and who you're passionate about. And that helps then to contain that ongoing stress of uncertainty, which can, as you've noted, be decades. Yeah. So you can live with just kind of wired from anxiety or create the richest life you can.
Okay. We've talked a lot, we've mentioned clinical trials. Only 3% of American adults are in clinical trials. There are new, Living Beyond Breast Cancer is partnering with breastcancertrials.org to put a new search tool to look for trials for women with metastatic breast cancer. So that is coming soon on our website. What are some other ways that people can get information on clinical trials, whether they're metastatic or not?
Every oncologist has gone through training at typically a university program that does research. Every oncologist is raised on doing research. We all know how to do it. The best source should be going to your oncologist and saying, I have this diagnosis. Are there any research studies I might qualify for that you think might be interesting enough to try? And that is a good source. There are roadblocks to putting patients on research studies. Number one is the oncologist may not be part of a larger group that has access to research studies. I'm part of Rocky Mountain Cancer Centers, which is part of US Oncology. We have a huge research organization, and we have access to a lot of drugs that the drug companies are developing and trying to test. We have access through our local CCOP, is our community cancer oncology program, having access to some of the other larger research organizations in the country, the NSABP, ECOG, all these different research groups. And as you know, the internet, you can go onto the internet and you can just plug in and look for research studies, but it takes extra time to do research. Your oncologist has to be committed to doing this because it will take more time for them to do that, but it may give you access to a treatment that is going to be some new home run in the future. And the only way of knowing for sure is to try these new agents. Sometimes they work, sometimes they don't. Sometimes people end up on the standard treatment and have unbelievable responses and do great. And people look back on, gee, I wish I had gone on this Herceptin adjuvant trial because maybe my cancer would not have come back if I had gotten it a long time ago.
Any other comments about clinical trials? No. It's where the new treatments are found. Many
So
people
all the new
do
exciting
fear,
stuff is, yeah.
Yeah, they do fear that they won't get the best treatment, but I think, as you said, I'd like you to just to expand on that. You get the best standard treatment or the newer treatment.
So the different thought leaders in breast cancer research are looking at all the different agents out there, and there are a slew of them now. Before it was chemo A versus chemo B, which was really, in the early days, was exciting because one was inadequate and one was a little bit better, and we kept getting better and better. But now we're smarter. We now have scientists looking at different growth pathways. And they were learning that cancer doesn't just grow by being stimulated by estrogen, or it doesn't grow just by being stimulated by the HER2 oncogene. There are all these new other growth pathways and multiple different ways of inhibiting those. So they're making all these little small molecules. They're making all these new little antibodies. And we've got all these agents to try, but we don't have the patients that are willing to step forward to try these new drugs. And the thought leaders are saying, we've seen the data in a petri dish. It kills cancer cells. We have seen this work in our mouse model. We've seen it work in maybe a monkey model. We know that this is an active drug. They've tested it in humans in what's called a phase 1 trial where, okay, we've got this drug. We know what dose we might give to a dog. Well, we're going to try it in humans to see how we can give it safely. And we'll also see if it worked. And they're looking at different cancers. And we've learned that, okay, drug A, this is how we give it, once every 3 weeks at this dose. Now we're going to test it in 50 breast cancer patients because we know how to give it safely. And we'll give it to 50 patients who have gone through many other treatments and they have now progressed. But it worked in 10 out of 50 patients who had been heavily treated. We know this is an active drug. We then tried in 50 lung cancer patients. It didn't work. Okay, we'll forget the lung cancer. So then they go to phase 3 trials where, okay, we've got this new active drug. We know this drug is already FDA approved. We know it has a good track record. Let's compare the two head-to-head, which means you're going to get active treatment. We know this one FDA approved drug works, and we've in the clinical trials earlier have shown this new agent works, you're going to get an active drug. It's not like you're going to get a placebo. People are worried, I'm going to be a guinea pig, I'm going to get nothing. That doesn't happen nowadays. We have very effective therapies that we're comparing and trying to get the next level up.
Great, thank you.
Can I actually respond to your question?
Sure.
It occurred to me that one of the things I've seen with many women with triple negative breast cancer is that there's a group that really wants to go find out about clinical trials, and then others who are very apprehensive. And I think that it's important to recognize that when you get more information about clinical trials, you're empowering yourself to get more information about what's out there, locally, nationally. But that doesn't obligate you to anything. I think it feels risky to some individuals to go and ask those questions. And I would invite you to rethink that, because in fact it can be empowering to know that there may be other choices, or if not now, when are you a candidate for a new option or a clinical trial? And so I just wanted to reflect on that a little bit.
Thank you. Both very helpful. Okay, we're going to get to your questions very shortly. But I do want to say to the panel, for people who have finished with that, who are able to finish with their treatment, what are 3 practical things that they can do to support their health, their general health? Linda Cooper, you want to start with that?
Well, that's really unfair to everyone else on the panel, because I think we have about 5 or 6 we all recommend. I certainly think that nutrition is important. Mm-hmm. I think that exercise is important. And I think the third one that we often don't refer to is to continue finding ways to support yourself. It's you, as Peggy talked about, the anxiety is not going to go away. Your concerns about family and job and all sorts of other things are not going to be diminished. So continue to seek ways to support yourself from here on in.
Okay. Peggy.
I would agree with that. I think that sometimes we think when we're out of treatment, we're done focusing on ourselves, and it shouldn't be that way. And it's still okay for you to set boundaries or do whatever you need to do. I would, in addition to the physical aspects, I'd also say to try to stay positive, keep away from the people who are negative. Well, congratulations, you finished treatment, but I know so-and-so, my cousin's neighbor's sister, right? And you know who those people are. I mean, I designated my kids when we would go to family events to say, if you see Aunt, I almost said her name, you see Aunt so-and-so talking to me for more than 2 minutes, you swoop in. I mean, those are the kinds of things that you need to do, right? You still need that bubble, I guess, for lack of a better word. You're still fighting it, and you still need to. It's okay to focus on yourself. That was a hard lesson for me as a woman, as a mother, as a wife, right? As a worker, it was hard for me to say, okay, I still get to do this, and it's 7 years later, and I still get to do this.
Dr. Sedlacek, what do you tell your patients?
The 3 things, and when they're done with therapy, they'll then say, okay, what can I do now? And so the things I tell them is exercise, cut your caloric intake of fat to 20% of your calories or less, keep your weight in the normal weight, healthy weight. If you're overweight, try to get your weight down. Studies have shown overweight women, obese women have a higher risk of recurrence. And for a lot of reasons, you're going to feel a lot better if you can lose that extra 20 pounds, which is really hard now because you're now menopausal and you don't burn like you used to. Easy to say. So you get your Fitbit and you make sure you get your 10,000 steps a day. And so those are three things I tell everybody. There are studies out there showing that from the Nurses' Health trial, the Nurses' Health study, that nurses were women who got breast cancer. The women who were taking aspirin had significantly less recurrence than the women with breast cancer who did not take aspirin. And they found that women who were taking 2 to 5 aspirin a week did the best. Better than one a day and better than just once a week. So I've actually had a handout I give to my patients of an aspirin program, which is a regular aspirin, 4 days a week, Monday, Wednesday, Friday, Sunday, which is every other day. You can't remember if you took it yesterday, but you know if it's Monday, Wednesday, Friday, or Sunday. And today's Wednesday, so I took mine today. I've been on this program for 27 years. There's lots of benefits on preventing clots and heart disease and breast cancer recurrence, colon cancer, pancreas cancer. There's lots of benefits. So that's another thing I tell them to do, that they can be proactive. And I tell them to try to live their life. Because when they're diagnosed, it is right there in their face. And every time they get a headache, oh my God, it's my brain, I'm going to die. But then it goes away, they just had a headache. And then when they get the working out in the garden, they pull their back muscle, like, oh my God, I got cancer in my bone, I'm going to die. And then a week later, their back gets better. I tell them this, and they know it's right here. And then a year later, it's over here. And then 2 years later, it's here. And then 3 years later, 5 years later, and then 10 years later, it's hopefully way back here. I also tell patients at the 10-year point with this specific cancer, because it is, quote, aggressive, if you've not recurred by 10 years, it ain't going to happen. You're cured. This is like a high-grade lymphoma. You go through big-time chemotherapy. If it hasn't come back in 10 years, you're cured of that lymphoma. Same thing with triple-negative breast cancer. You're 10 years out, you're cured. You're good. Go on with your life.
For women with metastatic disease, diet and exercise is also important, and living your life is important. Dr. Coons, you want to make a closing comment, and then we'll get to
Yeah, that would be great. So in addition to the really excellent suggestions that my colleagues have shared with you, at a very deep level, so many women with triple-negative breast cancer feel alone. And so my recommendation, in addition to what's been suggested, are the 3 C's. And the 3 C's don't stand for cancer, chemo, or CAT scans. They stand for seek contact, deepen your connections, and create community. Whatever that means to you relationally and in the context of your life, it does take a village, if you will. We're not designed to cope with life in general, much less cancer alone. So the 3 C's.
Okay. So if our technicians would put our call-in, text-in number, not call-in number, please, our text-in number on the screen. We're not taking calls. We'll get that. But I wanted to, while people are beginning to text in questions, or if you are writing on a pad, our volunteers will take a question. Ask about chemobrain in our survey that I talked about. Women, particularly women with triple negative, understandably, are concerned with chemobrain, and there are beginning to be studies validating this experience that at least our small survey of laughter when I said the word chemobrain confirmed. What do you tell women about chemobrain, Dr. Selichek?
This became more of an issue back in the 90s when we first recognized that patients who were going through high-dose chemotherapy and bone marrow transplant, so they were getting 10 times standard dose chemotherapy, blasting their cancers and then rescuing them with their own bone marrows. There were many women who came out of there with significant cognitive difficulties, and some of them actually never recovered. And that really raised the issue, well, we're giving 10 times standard dose, what do you expect? And specific, some of the programs were drugs that got into the brain. And that raised the issue of, okay, what's going on here? And it was then in the 2000s that we started realizing that women getting standard dose chemotherapy were complaining of, I'm just not as sharp, I'm an accountant, I can't keep track of numbers like I used to, I can't do my job. And then people started saying, well, we need to study this. We need to actually identify what's going on. People started doing cognitive psychiatric studies prior to chemotherapy, at the end of chemotherapy, doing MRI scans, trying to identify factors that might put a patient at risk. And we know it's real. Most patients who go through, and at least 25% of them will have significant enough cognitive impairment that they may not be able to perform the duties they were doing previously. But most of those patients will get better by 1 year. They're going to get better. The confounding factor is menopause, though. Because if you take a 45-year-old woman, she's working full-time, you give her chemo, you put her in a menopause, she's got cognitive impairment at the end of her chemotherapy. Well, some of that's actually the loss of estrogen and menopausal symptoms, such that the chemo brain may go away by 1 year, but she may still not be as quick as she used to be when she was 45 and making estrogen.
Okay.
Would you like me to speak to concrete steps
Yes.
to deal with it?
Yeah.
Okay. So what we recommend is decreasing multitasking for starters. That's a foreign concept to most women, and especially women with triple negative breast cancer.
But par for the course for us men.
Yeah. So decrease multitasking, use memory cues, watch that over fatigue and increase the pacing. Again, if you're not sleeping well, that further compromises concentration and focus and memory. Increase your aerobic exercise. Watch alcohol and other drugs as a maladaptive way to cope. Work in shorter intervals. So those are some quick examples of concrete strategies we recommend when you're coping with mild but nuisance-y changes in your cognitive functioning, especially when you're used to juggling so much and firing off and being sharp.
Great. Linda?
The final thing I would add to that is share that information with your oncologist and with the healthcare team. Don't just say, well, I'll get over this, or I don't want them to know I'm not as sharp as I was. It's important they keep track of it, and it's important they possibly are able to get you some of these wonderful techniques to recommend further testing. So share with it. Let them track your issues as well.
Great. Peggy, any advice to people?
No. What was the question? Just kidding. I don't have anything to add. I would just use it as an excuse for everything. That's how I dealt with it. So, true.
Okay.
Keep
Very
it
good.
Yeah.
A number of questions are coming in from both the in-person audience and our web folks about BRCA testing and triple negative. Dr. Sedlacek, what do you tell your patients? What do you recommend?
We know that if you are triple negative, you have a greater risk that you are BRCA1 positive. And the characteristics, the likelihood of being BRCA1 positive goes up the younger you are, if you're African American, and if you have bilateral breast cancer. And so if you are less than 60 years old, have no family history at all, but have triple negative breast cancer, you actually have a high enough risk of being BRCA1 positive that you need testing, which is something new that just happened in the last year and a half, 2 years, that we identified these subgroups of women who are more likely to carry the breast cancer gene, and specifically BRCA1. BRCA2 tends to cause the typical kind of estrogen receptor positive breast cancer that normal women get, average women who don't have a family history or a gene mutation, but they get it a little bit earlier. The BRCA1 patients they're the women who may get it at 35, at 25, at 45, as opposed to the average age of 61. So if indeed you're triple negative, even without any family history at all, you're 60 years old or younger, you need gene testing.
Follow-up was, what is gene testing? Why is gene testing not the standard for people over 60?
If you have a mutation of one of the breast cancer genes, BRCA1 or 2, they tend to get breast cancer early. And statistics show that if you can make it to at least even age 50 and not get breast cancer, or even if you get breast cancer after age 50, the likelihood of you being BRCA1 positive goes down significantly. So age is important, and also family history, such that if grandma had breast cancer, let's say at 55, your mother had breast cancer at 45, and we see this in generations that may get younger and younger, and you're now 35 years old and you have breast cancer, you very likely, and especially if it's triple negative, you very likely are BRCA1 positive.
Okay. Thank you. Someone asked very quickly, what kind of aspirin? Baby aspirin or regular
Actually, it's a
aspirin?
regular aspirin.
Okay.
You know, most men are taking a baby aspirin, 81 milligrams. They're taking it for their heart, and indeed that does work. But if you're looking at all the literature of aspirin going back the last 45 years, that the best compromised dose to get the heart clot benefit, but also the cancer benefits, it's taking the regular aspirin 4 days a week. Not every day. I was used to take it every day, but then the studies came out that indeed it increases your risk of hemorrhagic stroke. That didn't sound good to me. So I backed down to 4 a week. And the other bugaboo about aspirin is that it can cause gastritis and GI bleeding. So I always tell my patients, get enteric-coated aspirin. It's aspirin with a coating on it so it doesn't dissolve in your stomach, doesn't irritate the stomach, does not cause the gastritis.
Okay, great. We have a number of questions about finding a psychologist and how some people are frustrated that it has not been recommended to them. Dr. Coons, do you want to have anything to say on this matter? And then Linda, I'll turn that to you as well.
It's a great question. So we know, as a nation, there individuals are too infrequently referred to mental health providers. And in the case of the oncology setting, first of all, individuals need to speak up to any member of their oncology team if they're feeling the need to have some privacy around any part of this experience, whether it's coping with the diagnosis, making decisions, relationship issues, how to disclose body image, sexual health, cognitive functioning, planning for the future, whatever the example is. So the first place to start is with a trusted member of your cancer team. If that doesn't work for you, ask your primary care doc. Ask your GYN. Ask somebody who you trust to make a recommendation to refer you to a mental health provider who preferably has expertise in working with the cancer community, because this requires special competencies to, in fact, meet the mental health and psychosocial needs of this population. So if you meet someone and it's not a right fit, ask for another referral. Not everybody's going to be the right fit for you, and you need to feel like you're in good and experienced hands with somebody who's going to work with you where you're at. You can call your insurance company if you're really not sure where to go. You might ask someone in your community. There are times when the cancer hotlines have referrals that they will give you. You can call 800 numbers if you have to. But the first place to start really is with your cancer team. Many cancer centers have mental health providers, behavioral health providers in, whether they're psychologists or social workers or psychiatrists, have them as part of their teams, or work with individuals in the community who are trusted and have the expertise that you're going to want.
Linda, you add to that?
The only thing I could add to that is if a member of your healthcare team asks you if you think you're at the point you would like to see a therapist, a counselor, do not become offended. It's very easy we all have these sort of preconceived notions about what that might mean. What they're really saying to you is, could you use some additional objective support? And if we don't have the sense or the accuracy to know we need to ask that question, bring it up to us.
Very good advice. We have a lot of questions coming in about nutrition and diet. you know, how nutritionists are something you do find at large cancer centers, but a lot of people live in more rural areas. What are some strategies for finding out what your diet should be and how to perhaps lose the weight and do the things that you were suggesting afterwards?
One of my colleagues is a PhD up at Colorado State University, and he and I have been doing diet studies going back probably 10 years. Initially in high-risk women who had mothers and sisters with breast cancer, and then expanding into breast cancer survivors as the data was becoming available that being overweight was a risk factor for recurrence. And we started doing diets looking at the nutritional benefits of fruits and vegetables, and we actually had a diet where we were giving patients, they were eating 12 and a half servings a day of fruits and veggies. And we actually had some of our own healthcare workers on this diet. And what we learned is that, number one, you're in the kitchen a lot and you're chopping and cooking stuff a lot. And you're eating a large volume of food with lower calories, low cholesterol. And we had patients come to us and say, I cannot eat this much food, as they were losing pounds. And we've actually just published one of our studies of looking at a couple different diets where we have probably the best weight loss diet ever published, which was in our group of 350 so women. They lost 22 pounds in 6 months. We had some patients who lost as many as 50 pounds.
Wow.
My conclusion of all this, I changed the way I eat. I eat many more fruits and veggies than I used to. And while we don't necessarily recommend 12 and a half servings a day of fruits and veggies, I think possibly one of the best diets out there is fruits and veggies, fruits and veggies, fruits and veggies, and some meat. And actually, you could not be a vegetarian and be in our studies. You had to have some meat. And I think you get all these good things in the antioxidants you need. If you look at a lot of the supplemental studies looking at supplemental vitamin A and beta carotene and a lot of these other supplements, there are no studies out there to say it's going to help you. Scientific research has not really shown that's a benefit. You need to eat well. And eating well doesn't make up for the pizza you had and eating poorly. It doesn't allow you to eat poorly. You still need to be careful of what's going in your mouth.
Kind of get used to that routine.
Yes.
Peggy.
I also think that a lot of insurance companies have pre-diabetes plans, which have meal plans that are very similar, or diets that are very similar to the type of diet that you would learn from your oncologist or from their cooking classes and the things that they offer as well. So that might be another resource.
That's a good point, because we're finding now that the etiology, the carcinogenesis factors that cause cancer are also likely leading to heart disease, inflammation, and so the diabetes diet, heart diet, cancer diet, it's all about the same. All getting at that root problem.
I also think you have some websites, and the two that come to mind, and they are not the only two, are Cancer Cares and the American Cancer Society, where they have online, especially if you're not near a large university or a hospital, where you can get some basic information and take that information and talk to your oncologist and say, this is what I'm thinking of doing, what do you think?
Very good.
I want to add one comment about this important question in the context of family, however all of you define that, which is if you want to make this transition but you're getting pushback from your family, do it anyway. And it's a benefit to your entire family's health. And no one can do this for you. I think mostly if you have a candid conversation with any of your family members, they will begin to get it. But you may get some pushback of, well, why is there not a pizza on Friday night? Or, and it's important, again, to empower yourself to take good care of yourself. And your family will get it and also start to feel better and look better as well.
Great. And whenever we do panels and discussions like this, we always get questions about alcohol. You mentioned it's a bad coping mechanism, and I think people understand that, but is there any bit of alcohol that people can drink is what we're asking here.
Do you want to
Dr.
start?
Sedlacek, you want to start?
You know, alcohol is a risk factor for breast cancer. Every single study ever done looking at the effect of alcohol, the more you drink, the more breast cancer there is. Though there is a good level of alcohol, because drinking alcohol raises the good cholesterol, the HDL cholesterol, and reduces the risk of heart disease. And since heart disease is the #1 killer of people in this country, that drinking a little bit is good. And probably the absolute best amount is 3 or 4 drinks a week. Doesn't matter, it doesn't have to be red wine. It can be any kind of alcohol, 3 or 4 drinks a week. I don't drink enough. I'm working at night, and I may average 1 every 2 weeks. I need to somehow incorporate it into my diet, but those are extra calories. Those are the fun calories you have to account for that you don't like to. And so 1 drink a day is still okay. You're still going to reduce your risk of dying of any cause by drinking 1 drink a day. You're still going to reduce your risk of heart disease more so than you're going to raise the risk of breast cancer and other diseases. If you're at 2 drinks or more a day, you're getting diminished returns. You are increasing your risk of disease, including breast cancer. And it's amazing how many women I've talked to. Their lifestyle is, I have 2 glasses of wine with dinner every night. I'm not going to change that. And it's interesting, even after a diagnosis of breast cancer, they're pretty adamant about that. I said, I just want you to back off to 1. Nope, can't do that. Now, the question is, if you have breast cancer, that's the risk of getting breast cancer. Well, what if you have breast cancer? And so we have just carried over the thought that, well, alcohol is bad for you, so therefore you shouldn't drink at all. And I have many patients who have talked to other healthcare providers, to other cancer doctors, and been told, you cannot drink alcohol, period. You will die. There is a recent study about 1.5 years ago looking at women who had breast cancer and their alcohol intake. And actually the women who were drinking 3 or 4 drinks a week actually did a little bit better. So I tell my patients a drink a day is fine. You can't take all 7 drinks, though, and have them on Friday night.
You are such a stickler.
It averages out to 1 a day, but that's not good. That's not good.
Okay. We've had a couple questions about chemotherapy, and chemo is so toxic. It kills good cells while it's killing the bad cells. Are there other alternatives?
For triple-negative breast cancer, we're looking at new targets. One of the interesting points we didn't get a chance to talk about, I will talk about now, is that we've learned that 30 to 40% of women who are triple negative have the androgen receptor. I've been thinking about androgen receptors for 20 years, and finally, about in the last 5 years, people started looking at the androgen, male hormone receptors. 30 to 40% of these women are AR, androgen receptor positive. Guess what? We're treating them with a prostate cancer drug, enzalutamide. And guess what? It's working. So we're looking for new targets. So the term triple negative, I think, is going to become passé in the future, because we're going to find, well, they don't have these targets, but they've got these targets over here, and we've got new treatments for those. So there are alternatives, but the only way you're going to get those is by taking part in a research study now.
Very good. The questions are coming in. Just to step back a little bit, vitamin D has been in the news a lot related to cancer and health in general. What do you tell? Should people be taking supplements? Is there an impact?
The data on vitamin D has been coming in very rapidly over the last 5 years. And every week, every month, there's a new article looking at the association of low D levels and this disease. As I look at the literature, my thought is that the normal range of vitamin D is anywhere between 30 and 100. Yet studies show that if you can get your level above 50, it's probably going to be better. And so when my level of vitamin D was 42, taking 1,000 units a day, that kind of worried me. So I'm now taking 2,000 a day, and my level's up to 53. I don't have cancer. I'm trying to stay healthy. That's what I do, and I believe that D helps you absorb your calcium. It's going to help your bones. There's now studies showing that it may have something to do with breast cancer risk, breast cancer recurrence, colon cancer, prostate cancer, lung cancer, heart disease, immune disease, MS. I mean, the list keeps every week or month. There's a new study looking at the association of low D levels. And I believe it, and I'm taking 2,000 a day. I've got some women on 50,000 units twice a week to get their levels above 50, because I think there are studies to show there may be some benefit there. So that's something new in the last really 3 to 5 years.
Okay. Some questions have come in about alternative therapies. So I'm wondering, I'm looking at the social worker and the psychologist and even Peggy to talk about some alternative therapies that you would recommend as people go into post-treatment or are coping with metastatic breast cancer. Linda?
First of all, whatever alternative therapy sounds good to you, check it with your oncologist first. That it goes all the way from massage, which really can provide some stress reduction, some acupuncture for pain, again, meditation, yoga. Just be certain that wherever you're at in the course of your treatment, in your disease, whatever you're doing is going to add, not detract from what's happening.
Lynn?
So I'm not aware of trials of alternative treatment as primary therapy. I think, have you seen any studies?
No.
But you asked about post-treatment. So one thing I would say is, you've mentioned acupuncture and massage. I certainly see individuals who are adamant about any number of herbs for any number of symptoms. And I don't want to make a value judgment about the merits of those or not, except I tend to have two comments to my patients. One of which is, are there any data that they may help you, and in what way? What are the quality, and who's regulating what are you getting? And is there any risk to what you're taking that would diminish the effectiveness of other medications you're on? So you might finish acute treatment for triple-negative breast cancer, but in women across the lifespan, there's a good bet that you may be on other medications, and herbs and other supplements aren't benign agents. And so it's important to come back and ask your oncologist so that you're not inadvertently doing something that's potentially harmful or diminishing the effectiveness of a drug, in fact, where we've studied its effectiveness and safety. And that could be true for hot flashes, it could be true for depression, it could be true for any number of your sexual health. So I think, again, in the spirit of being empowered around your health, please bring all of what you're taking to your oncology follow-up appointment and say, is this stuff okay? Is that fair?
Yeah. Okay. Peggy, any insight? What have you used to cope as you've moved along?
Well, I haven't, anything that I would take, I would definitely ask my oncologist first, even if it seemed as innocuous as an herb that you might take every other day of your life. But I would think from my perspective, it's more in terms of approach versus therapy. I mean, everybody's approach is different to how you're going to get through this. This is your journey or your fight, depending on who you are. I know people that really needed to mellow out, find their zen, meditate. That's fine. That's not me. I'm not a gentle spirit. I've always wanted to be. I'm fight, 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 fight. And I think I think that you need to think about how you're going to marry those two. Your therapeutic, your medical treatment plan, and what that means to you as a person. How am I going to do this as an individual? And I think I think to look at that holistically rather than separate those out is, I mean, that worked for me, and that's worked for other people that I know as well.
Did you want to add something?
Just want to add one more comment that, especially in a group of women with triple-negative breast cancer, for whom after that acute treatment ends, we often see actually a surge in anxiety and distress anyway. But we know then that tends to then diminish in a general population of women with breast cancer. But this is you're a group that may not see that decrease. If you're simply unable to relax, to learn some relaxation skills, some mindfulness skills, or for some individuals that seems like completely out of your ballpark, to find ways to use exercise in a very helpful way, or a distraction. So I'm kind of lumping all of these, but it should be a cue to you if you just can't quiet down, to find different ways to do that, or to ask your providers in essence, learning to quiet yourself is a skill.
Okay, we have gotten a lot of questions about how do you get tested for an androgen receptor, and again, the BRCA testing. Should people who are, maybe a couple years out from their treatment and diagnosis, should they be tested, and should they have family members tested? So
doing genetic testing for BRCA1 or 2, and now there's actually very large panels. We've learned it's not just about BRCA1 or 2. There's CHEK2, there's PALB2, there's STK11, we have panels now with 29 genes. And so you can get gene tested at any time. We're actually now bringing a lot of our patients back because they were tested 5 years ago when they were initially diagnosed for BRCA1 and 2, but now we have these new panels and we're finding some of these new gene mutations, so we're bringing those patients back to get retested. So you get genetic testing anytime. Okay. As far as androgen receptor testing, that's really restricted for patients who have recurrent breast cancer, and we need a sample of tissue to test, and it gets sent off to a laboratory on a research study, and they will actually test to see if you're a candidate for that research study because you have that receptor.
Okay. Well, thank you. We are really running out of time, so I have a closing question for the panel. What an amazing dialogue we've had tonight. You set the table for great questions, and they've been rolling in. So the closing question is really, what is one message each one of you would want our participants to take away as they leave tonight? And Peggy, I'll start with you.
I think the one message that I would share with all the women in the room and women that are listening is that you can be a survivor. You can do it. Don't listen to the negativity. Stay positive. Do what you can. Stay focused. It's your battle. You're individual, and there's lots of help available to you. Reach out to LBBC. There are people who care about you. We may not know you. I'm sorry, I'm getting emotional. But we're a community, as you talked about, creating a community, and we are a community of support. And I don't know you individually, but I will help you to the extent that I can get over whatever hump to get through it.
Thank you. Linda.
Know what's important to you. Pick a team. Let them do their job. And given all the information you've heard tonight, if you are the sort of person who finds that you are constantly running to the computer to check out if there's anything new, give yourself the best present ever and appoint somebody your information czar and let them look at that and report back to you. Visit your oncologist and remove from yourself that one little bit of anxiety.
Great. Dr. Coons?
You all have the courage to cope with so many complex challenges associated with triple-negative breast cancer. So you certainly have the courage to empower yourself to ask questions and seek support.
Dr. Sedlacek.
The things I believe are important, which you've heard already, are get the information. Information is power. Get your team together. You got to feel comfortable with the people that you are entrusting your life with, and that might require a second opinion, maybe a third opinion. 11 opinions is too much. And really, the way we're going to advance this is research. Please think about it, talk to your doctors, look for something new and exciting out there. That's how we're going to find a cure.
Great. Well, please join me in thanking our amazing panel. I'd like to thank all of you in the audience here and online. I'd also like to thank our sponsors again, Celgene and AbbVie, and the Rocky Mountain Cancer Centers and the Women's Hospital at Skyridge. Thank you so much. See lbbc.org. We have all sorts of information. We have helpline volunteers like the amazing Peggy, Valdez, Olivas, and the number is on the banner there, and it's also on our website. So thank you so much for coming tonight.